We are live.
Good evening and welcome everyone to the DOS Postgraduate Education Program, DOS-PEP as we all call it. And we are currently in the third module, that is the Strabismus and Neuro-Ophthalmology. And today we are on the fifth class of Strabismus. And we have been completing the 50th lecture of DOS-PEP. We have an esteemed speaker with us, Dr. Janil Nilesh Sheth, who is going to be talking about a very important topic, which is ESODEVIAtions. So esotropia is something which is very commonly asked about in exams. You get long questions even in the practical exams and short notes in exam. And so it becomes a very important topic to understand the pathology of esodeviations and its management, which sir is going to cover in this current class. We also have our moderators with us, Dr. Gunjan Saluja, who has done her post-graduation and senior residency from RP Center, AIMS, and is currently an assistant editor in the IGO. And she has extensive experience in the field of strabismus, oculoplasty, and neuro-ophthalmology. We also have our co-moderator, Dr. Anita Gangar, who is currently a consultant in ophthalmology department at Sir Gangaram Hospital in New Delhi. And she's also done her senior residency from RP Center, AIMS, New Delhi. And our speaker for the day is Dr. Janil Sheth. He's done his DNB and FICU and is currently a faculty lead in pediatric ophthalmology department at Shantilal Sanghvi Eye Institute in Mumbai. He is heading the Center of Ophthalmic Training and Education at the same institute and has done his residency and fellowship in pediatric ophthalmology, strabismus, and neuro-ophthalmology from the prestigious LV Prasad Eye Institute. His clinical and research interest includes in the field of amblyopia, complex strabismus, and neuro-ophthalmic radiology. And he has authored over 22 publications and contributed to various book chapters in national and international textbook. He's presented his work at various conferences, and he's here to share with us the concepts of esotropia for the benefit of the students. So with this, I would like to hand over the screen and dais to Sir. And so you can start sharing your screen.
Okay. Is my screen visible now?
Yes, sir.
All right. Okay, so thank you very much, Dr. Pranita. Thank you for the kind introduction, and I would like to thank DOS as well as yourself and your team for inviting me for this. I think it's the 50th class, so quite a prestigious moment for DOS PEP program as well as myself to be invited. And I am a very keen interest in residency training, and squint strabismus is something which I had very keen interest right from the beginning, which is quite unlikely for many residents, as it is something where we are always worried and we read the textbooks and we don't understand most of it. But however, when you look at that practically, it's a quite straightforward topic, most of the things. So for today, I was told to present on ESO-deviations, a very broad topic for the next 45 minutes. What I'll try to do is cover certain aspects of it. So my objectives for this presentation is divided into 5 subchapters. That is classification, clinical features, pattern strabismus, in this case, pattern ESO-deviations, AC by A ratio, if it was not covered before, and conservative and surgical management. In interest of time, I'm going to focus on classification as well as clinical features, as this is something which is unique for ESO-deviation, because the other topics will be overall covered in other sessions, I suppose, and we can take one more session if DOS again gives me an opportunity to do so. So esotropia is a condition where the eye is deviated inwards or nasally, in a very simple language. And when we look at the Western literature and the Indian subcontinent literature, that esotropia is much more common in the Indian subcontinent and in Southeast Asia as compared to the Western literature, which says that intermittent exotropia is much more common. So if you look at all your large center data, and you will see that the esotropia is a much more common presentation in children as compared to exotropia, which is intermittent exotropia. This is the most common presentation how any child with a constant esotropia would present to you. Now, you never say that it is a left esotropia or right esotropia usually. For the understanding of the residents, you just say the child has esotropia and the eye which is deviated here is the left eye with the right eye being fixation. This is just a rough overview of how a child typically presents to you in your clinic. So we are not going into the details of motility, what is eye overaction. This is how a child would present. And you never mention it is left ESO or right ESO in a comitant strabismus. You mention that there is an esotropia with a right eye fixation and left eye inward deviation. Now, why I'm mentioning this? Because this could be your practical exam question where you will be mentioned that what is your diagnosis? You never say left esotropia, you never say right esotropia. You say this child has a constant strabismus, in this case, a constant esotropia with a right eye fixation and the left eye inward deviated, because it can be reversed. You can have a left eye fixation and right eye inward deviated. So if you observe the child for this fraction of second, the left eye is inverted, and you would say that it is a left eye esotropia. For the next second, you will see the right eye is. So you cannot have two diagnoses of left eye and right eye esotropia. You would only have a diagnosis of esotropia, whether it is infantile onset, whether it is refractive accommodative. We will come to those classifications, but right now we don't know the diagnosis. We just know the clinical presentation, which is esotropia. So how do we classify them broadly? Now, broadly, it is classified into two types, a comitant and incomitant. And I'm very sure most of the residents would know what do you mean by comitant strabismus, that the amount of deviation is equal in all directions of the gaze. Now, we know that the cardinal position of the gazes, there are 6 cardinal positions of the gazes. And if you look at central fixation as well as in the abduction and adduction, that is in the left and the right gaze, which we commonly measure. So in all the directions of the cardinal position of the gazes, that is dextro elevation, levo depression, dextro depression, the amount of esotropia, for example, in this previous child, the amount of esotropia is around 50 prism diopters, is equal in all the directions of the gazes. And that means this is a comitant esotropia. What do you mean by incomitant? Is exactly opposite. If the deviation differs in various direction of the gazes. So in one direction, like say in dextro elevation or dextro depression, you have less esotropia or more esotropia. That means it is not same in all directions. So it is incomitant. I'm sure this was covered in previous lectures. So these are the broad two classification, what type of esotropia. And this you only get once you measure in all directions of the gazes, which is kind of mandatory when you're doing a complete evaluation in any child or adult with strabismus. The comitant esotropia further is classified into 4 types. The accommodative type, one of the most common type. The microtropia, again, we are not looking at this in today's session, a nystagmus blockage syndrome, and the non-accommodative type. Now, I have not included infantile esotropia in the comitant section for some reason, which I'll come in the subsequent slides. And the incomitant strabismus now is divided into 2 types, the paralytic type and the restrictive type. Now, this classification remains if it is esotropia, exotropia, hypotropia, or hypertropia. So that will remain because you have paralytic and restrictive type of incomitant strabismus in any kind of deviation. So this is a common classification for any type of strabismus, but here with comitant esotropia, the classification is very peculiar for esodeviation. So one must remember you have an accommodative classification, you have a non-accommodative classification, you have microtropia, nystagmus blockage syndrome, and infantile onset, which itself is a separate entity. So I don't want to put it into comitant esotropia. Now, let us further see what do you mean by accommodative and non-accommodative, and what are the further sub-classification. Again, this is a long question where you will be given, so you need to make a complete flow chart. So this flow chart doesn't end here. It has a further flow chart where there are sub-classifications under each of comitant esodeviation. In accommodative, you have a further 4 types, which is a refractive accommodative esotropia with normal AC by A ratio. Again, AC by A ratio, if someone has not understood it, we'll cover it later in subsequent lectures. But if not, you can definitely read the standard textbooks to understand what do you mean by accommodative convergence by accommodation. There are 3 methods to measure it. But for this classification sake, let's presume that we know what is AC by A ratio. So refractive accommodative esotropia, normal by AC by A ratio, non-refractive accommodative esotropia where you have high AC by A ratio, something called as a partial refractive accommodative esotropia, and a hypoaccommodative esotropia where you have reduced near point of accommodation. In the non-accommodative subclassification, you have further many groups. Here you have an essential infantile esotropia. Now, why this was not one of the key component? Because the non-accommodative component has a very peculiar subclassification of esotropias, which is essential infantile esotropia. Now, this is very important. And when you go back to your MBBS days and you remember, if you are told about an elderly with hypertension, you never say it is systemic hypertension. You say it is an essential hypertension, because till today we don't know what is the reason for an age-related hypertension. So essential hypertensions have one, or essential is a diagnosis attached where you do not have a very cause which is very clear, which is very proven. So pathophysiology of infantile esotropia is a vast topic, but since we don't know a clear reason why the onset of esotropia occurs before 6 months of age in many healthy children, therefore it is called as an essential infantile esotropia. So essentially, you may just say that it is an infantile onset esotropia, but if you want this extra marks and your examiner is a strabismus surgeon or a strabismus specialist, and if you tell this terminology that this is a case of essential infantile onset esotropia, and I think you can get little bonus marks saying such terminology, because this is the typical classical definition of this condition. Again, a further classification of non-accommodative types are the non-accommodative convergence excess esotropia, where you have excess of conversion causing the esodiviation, which is more in near that compared to the distance, or even maybe same. Then you have something called as an acquired accommodative or non-accommodative comitant esotropia. Again, a completely different entity. In non-accommodative, these individual entities are like individual lectures. Then you have an acute onset esotropia, which is again a sudden onset decompensation esotropia, which is still comitant. It's not because of 6-nerve palsy, it's not because of restriction, it's still comitant. Then you have something called as a divergence insufficiency and cyclical esotropia. Very rare conditions. You may notice sometimes once in a decade, even for a strabismus surgeons, where you see the esotropia occurs cyclically every 48 hours, and otherwise the child is orthophoric or orthotropic the rest of the time. Coming to the third type, which is microtropia. Microtropias are of two types. These are small angle deviations or small angle esotropias, which are comitant, but they are of two types, which is primary or secondary. Secondary tend to occur post-surgery, and primary, which is just present right from the beginning without any surgical intervention. And they have very small angle and can cause very dense amblyopia. Again, we are not dwelling into that. Like I said, these are all sub-chapters, and we are going to focus on classification and clinical features of both them. And the fourth and the important type is the nystagmus blockade syndrome. Not very common to see, but yet a very important type of comitant strabismus, which you should be knowing about it, because you may get this in exam if you see very closely and find out these findings. This is again a bonus mark for you if you can find such cases. So quickly look at the epidemiology. The epidemiology is very poorly understood because we don't have that large volumetric population-based data, but roughly every 1 in 25 children, at least in the Indian subcontinent and the Asian children, we find that there is a esotropia which is common in children. Earlier, like the term congenital ET was considered this. Again, the congenital ET is a very false terminology, which is what, because it is not congenital, it is not by birth, it is onset within first 6 months of life. So the terminology used is essential infantile onset esotropia was assumed to be most common. But when we looked at certain data from the Indian literature as well as the Western literature, the accommodative esotropias as well as the infantile onset esotropias more or less were common in terms of their numbers. So the incidence of them is equal, same. The most common of all the classification which we saw here, the most common ones here are the essential infantile esotropia and the accommodative esotropia, within which the refractive accommodative esotropia and the partially accommodative esotropia are the common ones. Rest all usually are less in numbers when you look at the large volume data. So here a very old paper which was published by Mohini et al. The children with accommodative esotropia accounted for more than half of the study patients, and study patients were not many much. They were just 221 eyes, and they were nearly diagnosed 10 times more frequently than children with congenital esotropia. So what are the other types which can cause which does not come into the routine classification? There are esotropia associated with CNS defect, like primary pathology of the CNS, or acquired comitant esotropia, which is also called as AACE, acute onset acquired comitant esotropia. Sensory types of esotropia more commonly seen in children or adults, and commonly in children when you have a particular event which causes vision loss unilaterally, or visual deprivation because of cataract, trauma, corneal opacity, has more prone to call if the onset is much earlier, preferably before the age of 7 years of age. These children tend to develop esotropia as compared to those who have onset of visual deprivation much later. That after 7 years of age or the age of 10 years or 15 years, they tend to develop more exotropia. And now, why is that reason? There are some theories behind it. We'll not dwell into that in details. But if you have visual deprivation unilaterally in early age, then you're more likely to have a sensory esotropia. If you have vision deprivation, corneal opacity, cataract, could be any reason, or trauma, or choroidal scar due to trauma, you have more chances of exotropia if it is later in age. And the uncommon types is the paralytic types, where you have 6-nerve palsy causing esotropia, or trauma which causing esotropia. So these are the other types which are uncommon types. So let us go a little bit into the accommodative esotropia. So what do you mean by accommodative esotropia? Now, each and every word is important here. So an esotropia, which is due to some component of accommodation, is accommodative esotropia, unlike the essential infantile esotropia, which is the most common differential diagnosis in any child with ESODEVIATION. So esotropia, which is caused by increased accommodative effort or an abnormally high AC by A ratio, is called as an accommodative esotropia. Are these esotropias constant like the essential infantile esotropia? To begin with, not really, but yes, over the period of time, accommodative esotropia turn into constant, and they are usually exacerbated by illness. So commonly the complaints which you in your clinic, let us see the practical aspect. The child presents with an to you with an constant inward deviation of the eye. And when you take up the history, commonly the parents would say that it began 6 months or 1 year as intermittent. We noticed only once or twice in a day, but we ignored it. And the child had a period of illness, and suddenly we noticed there is a constant inward deviation since last few months, and that's why we are presenting to you, because now the eye is not keeping straight, it goes intermittently in. So important point to be noted, accommodative esotropias have a history of being intermittent in nature to begin with, but may turn to be constant. And usually there is an episode of illness or a fall or a trauma, which usually exacerbates this event of constantness. So it can occur at any age. But a point to be noted that the accommodative esotropias, the average age at which the child usually presents to is 18 to 24 months of age. So I've written yet to 4 years, but 18 to the recent literature data, when we look at large volume studies, we see that 18 to 24 means a common age when they start noticing the intermittent nature of the accommodative esotropia, which turns into a constant esotropia, and they come to the clinic for examination. Again, important thing, this is also one of the question in your DNB theory, that you must know what is SEMAS. SEMAS is a classification of eye movement abnormalities and strabismus. It keeps on getting upgraded. Essentially, what we saw, the classification of ESODEVIATION into comitant and non-comitant, and then comitant into subclassification, all is mentioned in SEMAS, which is classification of eye movement disorders. Now, these are the group of strabismus who classify different type of strabismus, and we are focused so much on it because the diagnosis is the first most important thing after a thorough evaluation in esotropia, is to know that what could be your management, because the management differs very variedly, and we are going to touch upon the management of various things. So SEMAS classified accommodative esotropias into further 3 types, which is pure refractive, non-refractive, and mixed. Now, somewhat similar to what we talked about is refractive accommodative, non-refractive accommodative, and somewhere which is hypoaccommodative, where it is included in the mixed component as per the SEMAS classification. So pure refractive is the one where esotropia is completely eliminated by spectacle. And usually by spectacle, I say, is usually accommodation. So you are going to have a plus glasses to relax the accommodation, and that would correct your esotropia, where esotropia gets better completely or within 10 prism diopters by a hyperopic glasses, is called as a pure refractive accommodative esotropia. Where you have a non-refractive, where esotropia only at near is eliminated with plus lenses at near, additional plus lenses, which is called as bifocal, and a mixed variant where esotropia at distance and greater at near associated with hyperopia, responds to hyperopic correction only at distance and with bifocal at near. So to make it very simple, you have an esotropia for distance and near. If it gets completely eliminated for distance and near with a simple plus glasses, it is called as a pure refractive type. And if the esotropia gets completely eliminated at near with a plus lens is additional, and in this case it is bifocal, then it is a non-refractive. And if it is a esotropia which is both for distance, but it is greater at near, and it is associated with a plus, which again responds to that correction. So it does not mean that adding that plus does not eliminate, it eliminates at distance and near with a bifocal, is called as a mixed type. So let us go into the refractive accommodative esotropia. Again, each word is important. Here, there is a refractive correction, which an accommodative component which is responsible for esotropia. So correcting the refractive error relaxes the accommodation and eliminates the esotropia, as simple as that. So correcting refraction eliminates the accommodation or reduces the accommodation, eliminates the esotropia, is RAET, or refractive accommodative esotropia. So esotropia that is restored to orthotropia at all fixation distances and in all gaze position, because it is committant by optical correction of the underlying hypermetropic refractive error, is refractive accommodative esotropia. A very quick example here, which is very easy to understand. Here you can see again there is a esotropia. Never mention esotropia right eye, left eye, right esotropia, left esotropia. There is a constant esotropia with the left eye fixation and the right eye inward deviation. On wearing spectacles of particular plus glasses, let's say in this case the child has +4, there is complete correction of the inward deviation on either side. So it is right eye, left eye, we never mentioned. There is a complete correction and is restored to orthotropia. So this is a child with refractive accommodative esotropia. Here in this case, without glasses, the amount of esotropia is 30 prism diopters for distance, near, and in all directions of the gaze. That is the cardinal position. On wearing glasses of +4 diopters, that is a full cycloplegic correction. There is no esotropia, there is no deviation. It has complete normal binocular vision and fusion in all directions of the gazes and restored to orthotropia by a hyperopic correction, also called as refractive accommodative esotropia. So why does it happen? Now, what's the pathology? I mean, why do these some of the children? So hyperopia is something which is there right since birth. And if you look at the phenomena of emmetropization, if you look at those literature and data on emmetropization, we are hyperopic by birth. Unless in cases of prematurity or low birth weight, where we have myopic because of the abnormal curvature of the cornea or abnormal lens shape, essentially our axial lens at birth is somewhere between 19 to 20 millimeters of axial length on either eyes, which is responsible for hyperopia of +1.5 to +3 or maybe +6 in certain cases, if the axial length is a little smaller. And what happens with time of emmetropization, that till the age of 2 years, there is an axial length elongation, and essentially it somewhere halts at the axial length of, which is the optimal axial length, which you see in most of your cataract patients, is approximately 21.5 to 22 millimeters of length. Anything more than that, you are shifting towards myopia. Anything less than that, you are still in the hyperopic phase. So this uncorrected hypermetropia in many of the children whose axial length does not exceed beyond 21.5 millimeter or halt somewhere between 20-21, or they have flatter cornea, which is also again responsible for curvatural hypermetropia. This uncorrected hypermetropia, which otherwise does not impair their distance or near vision for the first 2 years of life, have this retina image blur, which is obvious, and this induces an accommodation. And this accommodation, so when you want to accommodate, what happens, what is a near triad accommodation, comes with convergence. And what happens is conversion, this accommodative convergence is the one which is responsible for your esotropia, which is initially intermittent because the accommodation is intermittent and the convergence is intermittent. But due to certain event, like I said, if there is a illness or if there is a fall which exacerbate, it leads to a constancy which is responsible for a constant inward deviation of the eye. And correction can only happen when you correct the accommodation and the accommodative convergence. So basically, you correct the AC by A ratio with plus glasses, and they would correct your esotropia, and that is refractive accommodative esotropia. Now, retinal image blur will not always, if you see, there are a lot of uncorrected hyperops. So the second question will come to your mind is that there are a lot of uncorrected hyperops in your clinical practice. Why don't we see esotropia in all of them? So that again is a good question, something to be thought about, that not all of them will have that effort to accommodate. Some might be effortlessly. You have +4 +4 diopters of spherical equivalent in either eyes, but you have no esotropia. They are completely orthophoric. They have reasonably good binocular single vision. So they have no effort, so they will not have any esotropia. So they will be orthotropic. However, because of that high plus they would have retina image blur, which will be responsible for their amblyopia. So they will be mild to moderate amblyopia, sometimes even severe depending on the plus. But those with an effort will go into these three types. So if the effort is much, they will have into constant ET, and with combined with insufficient fusional divergence. That is, they do not have that sufficient vergence of divergence. So you have convergence and divergence. We have a very larger convergence amplitude, and we have a very small divergence amplitude. And even if the child has a very strong accommodative component and convergence, but at the same time does not even have that much of fusional divergence, which is just 4 to 6 prism diopter. So these categorize into normal or high AC by A ratio, and these are refractive accommodative esotropia. Whereas some of them will not have that much of accommodative component, but they have sufficient fusional divergence, and these will go into esophoria. So this is the initial presentation which we talked about at somewhere around 18 to 24 months, where parents will tell you that the child has intermittent. So why the child has intermittent deviation? Because the child still has sufficient fusional divergence. So there is a component of accommodation, but because of that fusional divergence which is sufficient, it relaxes the eye. It again goes back to orthotropia, and again it goes back to esotropia. These intermittent episodes would happen, but due to some reason which we don't know clearly why that illness precipitates, that precipitation occurs, and what happens is that the divergence insufficiency happens, which goes into a constancy, which is a refractive accommodative esotropia. Now there's a third arm to it, that what happens in accommodative convergence, that you have very low or flat AC by ratio. That is, your effort for accommodative convergence is very low, not very strong. So these may not become esotropic in spite of uncorrected hyperopia. So those two questions which can come into your mind, that we see a lot of uncorrected hyperops. Why these children did not have, as compared to other two children which we saw had accommodative esotropia, is these are the mechanisms which are taking place behind the scenes. So this is something which one must know, that what is happening and what happens in a child with simple pair of plus glasses, where one of them falls into this category, the other term falls still into this category, and the third arm falls into this category. Now, why is this important to understand? Because you have all these three class of children in your clinic, but the management completely differs in all. So all plus glasses do not require, all plus corrections do not require glasses. Those with accommodative esotropia will definitely require a full cyclopic correction. Those with esophoria will require correction only if they are amblyopic. And those with uncorrected, not esophoric, may not require any correction at all if they have good vision and they are not amblyopic. So this is very important to understand. I have taken much time for this slide, is essentially because this classification is easy, this understanding is simple, but why do we understand in depth is for this reason only, that we have a complete understanding of how to manage such cases. So clinical features, they present usually around, like I said, 18 months to 24 months, somewhere around 3 years could be the average. They usually present before the 7 years of age. They are exacerbated by illness. They usually have a moderate to small angular deviation. They would not be 50, 60 or 70 prism diopters of esotropia. They would usually have somewhere between 15 to 30 prism diopters. They either have normal AC by ratio at near point of accommodation. And remember, our near point of accommodation, or also called as NPA, is somewhere around 25 centimeters or 10 inches, where you see an image very clear with maximum effort. And usually the cycloplegic refraction is usually more than +4. But you still have a range. It need not necessarily mean that those with +2 or +3, this is moderate to low hyperopes, would not have the phenomena of refractive accommodative esotropia. And usually what other thing to be noticed by the previous reports, if the child was examined somewhere, there is a progressive increase in the angle and the progressive frequency in the angle of deviation and the frequency of deviation, which again comes from the history as well as comes from the good orthoptics workup. It was done before. And there are certain red flag signs. Again, we'll not go into the details. This is more from the fellowship perspective rather than residency. You must remember that refractive accommodative esotropia, if associated with a pattern strabismus, like a V pattern or A pattern, where the deviation is incompetent in up and down gaze, or if it is associated with a dissociated vertical deviation or inferior oblique overaction, these are red flag signs, and they need to be treated aggressively. They need to be treated promptly. And these are usually associated in 1/3 of the cases with a typical refractive accommodative esotropia. So management in this case, these are the patients with good prognosis. So if you correct their refractive error by hypermetropic correction, they have excellent binocularity, they have excellent vision, they have very less chances of amblyopia. So full correction is obtained by cycloplegic refraction. By full correction, I mean is you do not correct for the drug. You do not correct the tonus allowance of the drug. You give full correction of what you measure after cycloplegia, after 45 minutes or 55 minutes of cycloplegic refraction. And of course, there is an initial blurring, and which atropinization for a brief period may be required in certain children. Let's say you have a 5-year-old kid with a refractive accommodative esotropia, and the child is a very high +6, +7. The esotropia completely eliminated or resolves with a plus correction, but the child may not be able to tolerate such high plus lenses, and sometimes the atropinization for a brief period not only relaxes the accommodation, but during the same time it also allows the child to accept the high plus glasses and to accommodate with that high plus glasses to have a clear vision. So remember, in any case of strabismus, vision first, deviation second. So vision is the first thing to be corrected and has to be optimum, and then you go behind the deviation. Contact lens, again, a very good option in high hypermetropia. There are a lot of literature on it. And there are also some literature on role of miotics in such cases. Of course, we don't have phosphopolamine here in India, but pilocarpine is, of course, not a good choice, which we know about the side effects of pilocarpine, which is again a pharmacotherapy for correction of refractive accommodative esotropia. But the commonly what we use, and very sparingly or never we use this pharmacotherapy, the glasses prescription on the optical correction is the best means to correct RAT or refractive accommodative esotropia. The common follow-up what you maintain is 3 to 6 months. For two things you want to follow: whether there is spectacle compliance, if there is a myopic shift. Remember the phenomena of emmetropization, that as the child grows, the amount of plus lenses the child would require would be lesser. So you need to screen them every 6 monthly or yearly if the plus is reducing, because you need to sometimes a refractive accommodative esotropia corrected completely might go into a consecutive exotropia if you continue the plus lenses, even though the child has a myopic shift. So if you have a +4 prescription and 1.5 years later, the +4 becomes +3, but you continue to have +3, the child will develop intermittent exotropia or exotropia because the accommodation is too much relaxed now, and the child does not need that high plus. In fact, the child needs some effort. So how do you give effort? You reduce the plus, and that is the best way. And that is what we are looking at in such patients. Amblyopia and RAT again needs a very aggressive management. And red flag signs of decompensation to non-accommodative esodiviation, that you have something which is corrected by hyperopic correction to complete orthotropia, but either illness or some untoward event, or red flag signs like oblique overactions, TVD, amblyopia, or trauma can go into a decompose into a constant strabismus in spite of full correction. So that falls now into a non-accommodative constant esotropia. So monitoring is very essential. It's not that it's a one-time phenomena that you give the glasses and you tell the child to directly turn when they turn into teenager, is a completely wrong practice. So they need to be monitored every 6 monthly. And this is usually to incrementally reduce the plus lenses and to encourage the expansion of the fusional divergence, which eventually will correct their esotropia. So let us now quickly go to the non-refractive accommodative esotropia. So here again, an accommodative component is still there, but it is not because of the high hypermetro, and it is one which is responsible for esotropia. The terminology should be very clear. So esotropia greater at near than at distance, unrelated to the uncorrected refractive error caused by an abnormally high AC by A ratio in presence of a normal near point of accommodation. So your NPA, which is still 10 inches or 25 centimeters, where it is with maximum effort of your accommodation, you are able to see at 25 centimeters. But the AC by A ratio, which normally is 4:1 or 5:1 or 4 to 6:1, is very high. And this esotropia has nothing to do with the refractive error, which is usually a plus lens in this case, but it does not resolve with that plus lens. Is the non-refractive accommodative esotropia. Accommodation is still there, but unrelated to the plus lenses or the correction. So this is again frequently seen in hyperopia, like I mentioned, but it is sparingly seen in myopia and emmetropes also. Commonly age group again is a similar age group where 18 to 24 months or roughly around 3 years of age. They have high AC by A ratio because that is what is the clinical feature of this non-refractive accommodative types. And children with hyperopia who develop esotropia with high high AC by ratios when compared with similarly matched hyperopic children without strabismus. So this again is a very important component. The number of children actually who have this high AC by ratios are actually similar to the number of children who have hyperopia, but they are without strabismus. So again, interestingly, that the pathophysiology which we are trying to understand why it happens in some and why it doesn't happen in some is because ultimately because of the accommodative effort with the child puts into. So there have been studies where they have also understood they have done a psychometric as well as psychological analysis where these are the children with certain type A personalities, those who are very much concerned all the time or are very overachieving or ambitious, usually with hyperopic correction, vis-a-vis another child who is otherwise an introvert and not very overachievement, ambitious, not with typical type A personality, will not have a component of esotropia as compared to the first child what we discussed. There is some abnormal synkinesis between accommodation and accommodative conversion where usually there is synergy. And there could be two reasons. One, there is still a sufficient motor fusion, which is responsible for phoria and not a manifest deviation. And where there is insufficient motor fusion, which is responsible for your atropia. So in spite of an refractive correction, which is given, still there is a constant esotropia. This is because of the high AC by ratio, which is again, we don't understand why it has happened, but if you want to classify it, then it is either because of sufficient motor fusion, which will just cause a transient tropia or a phoria, or insufficient motor fusion, which is responsible for a constant inward deviation, which is esotropia. So how do you manage them? You manage them for the high AC by ratio. The management is a bifocal add. So you give them full correction, which is not going to do any change or not change much more than 10 prism diopters of inward deviation. So you add a typical executive bifocal where there is a near segment, and the near segment usually where to have the near segment? The near segment usually bisects the pupil. Now it should bisect the pupil when the child is younger. As the child grows old and child achieving towards teenager, this bisection of the pupil actually should go down and down. So what do you mean by down and down is that initially when the child is younger, and you would say that in class 1 to 3 or somewhere between 6 to 9 years of age, you have the executive bifocal segment where the child does not have that ability to read through the ability to read with the down gaze. So, and the child usually tends to turn the head. So the child continues to look from the distance glass and will never look through the near ad. For forcing the child to look through the near ad, we usually give an executive bifocal which bisects the pupil. So the child has to forcibly look at the down gaze. But as the child grows old and now the child can actually read through the down part of the lenses, what you can do is, in order to not disturb the distance vision, the bisection of the segment can keep moving down. So this segment of bisection can actually come down to the level of either the lower margin of the pupil or even beneath that, depending on how the child is comfortable. And this has to be dealt in the clinic to understand the child's need and how is the child reading, and measuring when the child is reading for distance and near to understand where the bisection should be. Now, the other type is the flat top, or typically the D bifocal, where again, this is again suitable for certain children who may not prefer to have executive bifocal, because for them, their reading habits are a little different. For looking distance, it is different, and they would always be uncomfortable to look at distance with their lower segment because it usually comes into their visual axis. So essentially a bifocal add, but a lot of science into what type of the appropriate correction to be given. What happens because of this additional add, it relaxes this high AC by ratio, reducing the convergence. So moment you reduce the accommodative effort, it reduces the convergence also, because we know that convergence and accommodations go hand in hand. And the purpose of the binocular bifocal is to preserve binocular vision and fusion to develop at all distances, so that the plus lenses, which is the usual hypermetropic correction, will correct their distance deviation. But the additional plus, because of the high C by ratio, will correct the near deviation. And why this near and distance is important? Because when you go back to the definition, the terminology, non-refractive accommodative esotropia, it's not the plus component, it is the accommodative which is responsible. And for this accommodation, how to manage that accommodation is to give it the extra plus. How do you give the extra pluses? In the form of a bifocal segment. And now, how much to continue? Are progressive lenses also good? Lot of literature. Yes, progressive lenses also have a good role, but progressive lenses are also responsible for change in the contrast. So is it good for children with amblyopia and non-refractive accommodative esotropia? A lot of literature into it, but for the practical purpose and for your exam understanding, bifocal is the treatment of choice. Either you have executive bifocal or the flat top bifocal. Progressive pulse are also one of the methods to correct non-refractive accommodative esotropia. How long do you continue? Usually up to the teenagers, where you have relaxation of the ciliary muscles and reducing the accommodative effort. So usually up to 13 to 14 years of age, reducing the bisecting segment of the executive bifocal is important. And in certain cases where you have a decompensation, that the plus lenses do not even correct the near deviation, you may sometimes have to do something called as a Farden of the medial rectus, or a bilateral bimedial rectus muscle recession is again a treatment of choice in such cases, which is a surgical management. The third type is the hypoaccommodative esotropia. Again, the esotropia is greater at near than distance, unrelated to the uncorrected refractive error caused by excessive convergence from an increased accommodative effort to overcome a primary or secondary weakness of the accommodation. Very confusing. We need to read this twice or thrice to understand. Essentially, again, you go to the terminologies. Accommodation is less because it is hypo. To overcome that accommodation, I want to accommodate more because my point of the near point of accommodation is now remote. It's gone distance. So something which I want to read a book at 25 centimeters, I'm not able to read it thoroughly or clearly. I will try to over accommodate it. What happens is over accommodation, convergence comes in. What is convergence responsible for? Esotropia. So excessive convergence from excessive effort leads to esotropia. This is the terminology, a relatively rare type, not very frequently seen in the clinic, but to understand its terminology, always just divide these words and understand as hypoaccommodative esotropia, less accommodation, overcome accommodation, more effort, more esotropia, more convergence, more esotropia. Clinical features, they usually have very small plus lenses. Sometimes they have myopia correction also. They have very remote NPA, like I said. So now their near point of accommodation is not 25 centimeters, but just like a 40-year-old at 33 or 40 centimeters. So they do not see anything clearly between 25 to 40 centimeters, and things only become at far, not at near. They usually have very small distance, but very large deviation. There is a near distance disparity. So you don't see a near distance disparity in a refractive accommodative esotropia. You see a near distance disparity in a non-refractive accommodative esotropia, and you also see a near distance disparity in a hypoaccommodative esotropia, but with those subtle differences like we saw in the previous slide. So more effort required to clear the vision and excessive convergence, which is responsible for this. How do you manage it? You relax. You use cycloplegic agents. You give exercises. There are orthoptic exercises to increase the amplitude of accommodation, to essentially increase the convergence without much of accommodative effort. So they have good convergence. They have to less accommodate, so they will have less esotropia for near. And interestingly, sometimes even though they are hypoaccommodative, but the effort is more, you want to reduce the effort by using the bifocal. So bifocal is also a treatment of choice in hypoaccommodative. So these patients, like I said, are quite infrequent and they need to be treated on case-to-case basis. There is no one clear guideline management for such cases. We'll go to the something which is more common, partially accommodative esotropia. Again, you can say is a form of very easy to understand. It's partial, it's accommodative, and it's esotropia. So it's essentially a kind of partially refractive accommodative esotropia. Again, accommodative factor contributes. They do not account for the entire deviation. That means even if you give correction, they partly correct the esotropia, but not completely. It is, you can say, an evolution of a purely accommodative esotropia. And in one way, it is a decompensated. So something like a plus classes corrected the esotropia completely. The patient or the child is now orthotropia. But for some reason, it did not correct completely. There is a small residual esotropia which is remaining in spite of that. And these are the children with partially accommodative refractory esotropia. Onset again is somewhere around 18 to 24 months. More or less, these type of esotropia, acquired esotropias, have onset before the 3 years of age, but it can be as late as even 7 and 6 years of age. Also, they usually have poor compliance with glasses because they essentially do not require those plus lenses for vision because they have essentially clear vision, but very good poor binocularity because of the constant small angle strabismus. They may or may not have high AC by ratio. they require aggressive amblyopia therapy because of the small constant ESO-deviation. They usually have dense amblyopia, and that could be responsible for that poor binocular vision. So they require very aggressive amblyopia therapy. The uncorrected hyperopia needs to be treated very aggressively in such patients. And again, same reason, if they have prolonged illness, some untoward event, which is usually responsible for these children with uncorrected refractive errors to have this partially accommodative esotropia. So what is the amount of esotropia that should remain? One may ask that if I have 30 prism diopters, if I wear +4 glasses and I measure the child after 6 weeks or 3 months, then they have a residual esotropia of 10 or 12 or 15. That is anything more than 10 prism diopters for distance and near, despite full cycloplegic correction, prescription of the bifocal lenses or single monovision lenses, they would still have a residual. So these are purely partially accommodative esotropia, could be refractory, could be non-refractory. So very typical example here, you could see that again, this child has a plus correction. He has a 45 prism diopters esotropia, and giving this plus correction, there is a barely improvement, only 15 prism diopters. So here he is partially corrected in terms of his esotropia, even with the full cycloplegic correction. And these are the typical features, unlike what we saw previously, where there was a complete correction of the esotropia to orthotropia. So here the management is very simple. First thing, in this child, because it's a relatively older child, came to us high plus on examination on refraction, cycloplegic refraction, again higher plus, gave full cycloplegic correction, but had been esotropia for a longer time. So definitely I would presume that the left eye in this case would be amblyopic due to strabismus. And yes, it is. So it requires a very aggressive amblyopia management because they are already decompensated and they have very poor binocular vision, binocular fusion. So you prescribe full glasses, aggressively manage, and such cases usually will require surgery because we have already done a full accommodative correction. So surgical management is again similar to a non-accommodative esotropia, and the choice of surgery is usually bimedial rectus recession or sometimes even unilateral recess reset if the child is amblyopic densely. And when to do it, of course, is a question of the is a debatable question, but that we can discuss some other time. But this is the management per se for any child with a partially accommodative esotropia. So non-accommodative esotropia, again, this is the second component of the competent esotropia. We'll quickly cover in interest of time. Two important things here we are going to cover is the essential infantile esotropia, a non-accommodative convergence excess, acquired onset competent esotropia, also called as AACE, abbreviated as acute acquired competent esotropia, which is AACE. Actually, acquired basic esotropia is somewhere where which is not something which is acquired over the period of time, but the onset is very early. The AACE is the component which can be acquired at any age group and with any kind of refractive error, and more commonly in myopes as compared to hypermetropes. They have other further 3 classifications. Will not dwell into the details for it. Another component of it is a divergence, excess, or paralysis. A cyclical esotropia, like I mentioned, which happens cyclically every 48 hours, and recurrent esotropia, which is commonly seen post-surgery and amblyopia therapy also. So here we'll discuss more about the essential infantile esotropia, also old terminology called as congenital esotropia, which should no longer be used. And again, a very common type of strabismus in the Indian subcontinent, like we said. And these are usually manifest strabismus. Onset is either at birth or before the age of 6 months of age. Commonly, you would notice that if you do a FAT scan, by FAT scan, I mean in the family axial tomography, you look at all the old photographs, the esotropia will be more started noticing at the age of 3 months, and it will be very evident by the age of 6 months. There are 2 findings of these essential infantile esotropia. There are consistent findings and there are variable findings. So when you're looking at consistent findings, what are the consistent findings? These are must findings. This has to be there in your history taking an examination. That is, onset is before the age of 6 months. They're usually large angle. Usually, it's not a rule, but you will find that this is consistent. They are usually more than 25-30 prism diopters, can go up to 100 prism diopters. They are stable. So remember what we spoke about in refractive accommodative and non-accommodative refractive esotropia. They are intermittent. They progress over the period of time in terms of frequency and deviation. Here, they are stable. So again, if you are asked about how to differentiate between RAAT and essential infantile esotropia, these are the points of consistency. Now, occasionally at very early fixation preference. So they would either have a right fixation or left fixation, or sometimes they would alternate. They are otherwise neurologically normal. And if you use an optokinetic drum and you look for the asymmetrical optokinetic nystagmus, so they usually have a temporal to nasal asymmetry. So this is again this is a must and a consistent finding to look at. I'm sorry, nasal to temporal asymmetry, where you have a must finding in patients with essential esotropia. And sometimes when you are confused between a infantile or an esotropia, which is a congenital 6-nerve paresis, where you're not able to ascertain whether it is committed or non-committed, and optokinetic nystagmus or OK in term is the best test to determine whether there is any nasal temporal asymmetry or not. What are the variable findings? There could be amblyopia. If you have a fixation for right or the left eye, which is right from birth or before 6 months of age, and you have an apparent defective abduction, and which is also called a pseudo limitation. And this is because of strong cross fixation, that when you look to the left, the child uses the right eye. When you look to the right, the child uses the left eye. And this cross fixation may be responsible for the contralateral eye abduction, which is also called a pseudo limitation, or apparently excessive adduction because of the increased medial rectal overaction. Up or down shoot on adduction, again a very uncommon finding, again because of the medial rectus contraction or tightness in a large angle strabismus, presence of a pattern strabismus, which is the A or V pattern, and abnormal head posture, which may be there because of amblyopia and large angle strabismus, a dissociated vertical deviation or a dissociated horizontal deviation, a relatively common finding in 1/3 of the patients, a manifest or a latent nystagmus. Old terminology is now called as fusional nystagmus. So that's very important that you know that fusional manifest nystagmus is a maldevelopment nystagmus, I would say, not manifest nystagmus. Is a new terminology which to be used and could be hereditary. So you have a family history in the parents or in the grandparents, a history of infantile onset esotropia, and you have the child present to you. But these are all variable findings. So these are not must to have, but they may be associated. But these are the consistent findings in any child with infantile onset esotropia. So what's the etiology here? There are many theories. There are old theories and there are new theories. The new theory which say there is defect in the fusional faculty or the defective motor fusion. So either they have high AC by ratio right from birth, or they have increased tonic convergence, and like we know, more convergence, more accommodation esotropia, or they have uncorrected hypermetropes, which is again a less common finding because this may or may not be responsible for constant ESO deviation from first 6 months of age. And this all is because of the immature visual system, deficient motor fusion, which is responsible for esotropia with or without nystagmus. What are the old concepts? There are two theories. If you go to your A or textbooks, there is the Wirth theory and Chavase's theory. The Wirth theory states that there is a congenital defect in the sensory fusion mechanism, which is somewhere in your motor cortex, where two images from the right and left eye do not fuse. And because of that malfusion, there is a defect in the sensory mechanism, and this is responsible for constant inward deviation, or the Chavase's theory, which says that there is a motor fusion problem. Where there is an abnormal binocular vision, and this mechanism is responsible. The sensory mechanism is intact. It's the motor mechanism which is not intact and which is responsible for strabismus. So the management here is first always vision is the first important thing, and deviation is the second important. Always manage the vision first. Amblyopia correction is must, and 100% needs to be done as much as possible, as aggressive as possible. The goal here is to align the visual axis to promote the development of binocular vision. Remember, binocular vision we do not have right from birth. It starts developing from the first few months of life, and this only develops if you have a good motor fusion. So your motor fusion needs to be good to have a good sensory binocular vision. So surgical, of course, is the best treatment of choice, either bimedial recession, or sometimes you have to use 3 muscles in case of deviation is more than 60 prism diopters. In case of very dense amblyopia, the child is relatively older, you can choose only the amblyopia eye to operate in. And botulinum toxin again is very frequently used in West as the first line of management also by David Hunter and group, which is again has given reasonably good reason, but needs to be sometimes delivered once again or repeated with reason, and you may avoid surgery even with Botox in such children. So consistent findings, variable findings, and management, which is pretty straightforward. Timing of the surgery is another question. Practically, if a strabismus examiner is there, may ask you that what is the appropriate timing. This is still a very much debatable. There are every year you may come up with new studies where the appropriate timing keeps on changing. But if an answer has to be given, then the best timing is not too soon, not too late, and is usually before the second birthday. So that is 24 months. This particular paper by Krimenotol is most likely to result in measurable stereopsis if the patient age at alignment is not more than 16 months of age. So, of course, I said about 24 months because that is the time where you are able to give, where you are able to have good measurements, as well as you are able to preserve or restore the stereopsis by giving good motor alignment before a particular age, and that age is usually 2 years of age. So you may notice the child at 6 months, you need not operate immediately, you need not operate at 9 months, you can continue the amblyopia therapy, occlusion therapy, or atropine therapy, whichever you are using for amblyopia management. And if the child has cross fixation, it is excellent because the chances of developing amblyopia is less. You need to have stable measurements for 2 or 3 visits, which is over 6 months of time. And once you are very sure of the stable measurements, the best time is to operate at that time because you're sure of the outcome. Then there are less chances of recurrent strabismus, less chances of overcorrection, less chances of undercorrection. So the usual timing of surgery is just before second birthday or 24 months of age. So this covers the essential infantile esotropia, one again component of the comitant strabismus. So to summarize, we have classification of esodeviation, which is based on history and clinical features, and look at each terminology. And from the terminology, you can break up the words and you can understand what is the reason. Essential to do a very thorough squint evaluation because each terminology will come with evaluation. So if it is refractive, you know that it's refractive accommodative. If there is hypoaccommodative, you know with NPA and NPC. So these are the all components of strabismus evaluation, which I'm sure must be covered or be covered in the subsequent classes to know that which type of ESO deviations you are dealing with and how do you manage. And timing is the most important key for optimal outcome. So this covers the classification and clinical features of the type of esotropia. I have not covered acquired onset esotropia in interest of time. I've already exceeded some time. It's nearly 8:30. So thank you very much. I'm happy to answer the questions from the residents. Uh, uh, Dr.
Thank
Pranita.
you, Dr. Jenin, for that wonderful presentation. You have covered almost all the aspects of esotropia. You have covered accommodative esotropia quite in details. So I think yes, so there are a few questions. First of all, for why amblyopia is more common in patients with esotropia as compared to exotropia patients?
Well, that's a very good question, actually. And this is commonly which used to come to us. So remember that a small angle esotropia can have a very dense amblyopia as compared to a very large angle exotropia also. And the reason being is, now you look at the images, if you read our standard, the basic science, the AO books, and you have to go back to those images and see what kind of deviations cause. So you have a foveal fixation in one eye and you have a non-foveal fixation in other eye because of the constant strabismus. Now, in case of esotropia, the non-foveal fixation is causing a central suppression scotoma. Whereas in case of exotropia, however constant or intermittent, is causing a bitemporal suppression. It's not involving the fixation. So for this reason, even a small angle strabismus causing a central suppression scotoma would cause a very profound amblyopia. Because where is your maximum acuity? What do you mean by acuity? Is basically a foveal fixation. And that is what is involved in case of constant. So microtropia, very small angle, but causing a very dense amblyopia is again important.
Even there is a rivalry between the two eyes, between the nasal field of the two eyes, which are strong. So that is one of the other reasons which causes this thing. Then you had discussed in short about the cyclic esotropia also. Someone is asking about the management of cyclic esotropia. How do we manage it?
Okay, so difficult. I have only seen one, and very honestly, and how management is two ways. Surgery is one management, which we have noticed. Now, what surgery you do, how much you do is all depends on when you get the measurement. So here, the counseling by the parents is very important. You basically have to counsel the parents to bring the child when they have these episodes of esotropia to measure. That is one, because you want your target angle. Because either you have a large angle or moderate to large angle esotropia at the time, which is the cyclical episodes, and you have no esotropia or near orthotropia at the other time. So usually it's a 48-hour cycle, and surgery is one, Botox is one. If there's a full correction, of course, amblyopia management is the first thing which we will do. How much to do surgery is a question, but for some reason, even though they are cyclical, the manifest deviation when you correct it with the usual dose, for some reason, it eliminates the cyclical episode of esotropia. But very honestly, I do not have much experience. I have seen only one case, cyclical esotropia.
So basically, they correct on the day of presentation, whatever is the deviation. So that is
and it's repeatedly stable. So let's say they get every 2 days to you, and sometimes it is every 14 days also.
You need to re-measure. Yes. So about infantile esotropia, what are the common differential diagnoses which students should keep in mind when they are dealing with the case of an infantile esotropia?
Now, like I said, essential infantile esotropia, there are certain very typical classical characteristics which you must know. And one of the common thing which you must know, that if you have a fusional maldevelopment nystagmus and you have an OK interim, and you can know there's a nasal temporal asymmetry, then you are very much looking at infantile esotropia only, and there is not much of differential. But let's say you don't have that, you are very unsure. So commonly you think of an onset which is at 1 year of age, that you think of a congenital 6 now. You think of Duane syndrome, DRS. These are the common differential, but sometimes you have a Duane retraction syndrome with very minimal retraction, or Duane sign retraction where there is no retraction. Here, it could be a tricky and challenge. It's very important to measure in all directions, or very look at this subtle. Though we didn't cover that aspect of examination, because I'm sure it's covered, that you look at ductions and not at version. So you have to look at monooculated, close one eye, look at ductions carefully. Very important to examine that.
Basically, sometimes, patients with these infantile esotropia, they might have a very strong cross fixation. So because of that, it feels like their abduction is limited.
Definitely.
But however, one should keep in mind that a bilateral 6-nerve palsy, congenital 6-nerve palsy, is very, very rare to found. So it's rare thing. So rare things are rare. Okay, and what is the dose of Botox that is being given? As you have mentioned several times in your presentation also, that Botox is one of the modalities now.
What is a very old follow, and Alan Scott started with Botox many years ago. There is a Scott's rule for certain Botox is dependent completely on the amount of deviation. So it's not that you randomly give. So if it is mild to moderate, you give around 2.5 units. If it is large angle, you give around 5 units. So you measure the amount of deviation, and the Botox duration will be Botox dose will be so roughly around 0.1 ml, 0.2 ml, and 0.3 ml, which is roughly around 2.5, 5 units, and 7.5 international units. And this is for mild, moderate, and very large angle strabismus. If you follow, it is not the first line treatment even in standard textbooks as well as for us. But yes, it is one line of management for certain cases.
Yes, so I think they should know about the dose which can be asked in some of the exams. And one more important thing which we should cover is about the pseudo-esotropia. So pseudo-esotropia is one thing which is very common. Pediatricians usually send the patient stating that it looks like a esotropia. So can you just throw some light on the causes of pseudo-esotropia and how to differentiate them from true esotropia?
So that actually in the classification, the first classification should come as pseudo-ET and true esotropia to begin with, actually, because pseudo. So most commonly in pseudo-esotropia, of course, there are certain ethnic populations where pseudo-ET is more common, but the nasal bridge is quite broad, or you have epicanthal folds in terms of appearance. This is the where you have a pseudo-ET appearance. But a simple Hirschberg reflex test is the first way to know whether it is the central is there or not. And the center simple test to do with the Hirschberg, combine it with the cover uncover test to know if there is a esophoria or esotropia. But the common reason you need is even there are causes for pseudo exotropia also, but common reason here is certain ethnic populations, broad nasal bridge, epicanthal folds. These are the common reasons where pseudo esotropia would be there. It's important to know, and of course keep in mind that's the first thing to be kept in mind.
One more thing is the retinopathy of prematurity, which can cause dragging of the fovea.
Yes.
So
Dragging of the fovea and the macula, dragging of the macula, which will also. So this can be eccentric fixation, and it may appear as ET, but you see, so again a different classification, which will also cause very much agreed.
So I think that covers almost all the aspects of esotropia. The one more question is there, that suppose if a patient is having accommodative esotropia, so what are the factors which you have found or come across that affect the response of the patient with glasses?
And then I didn't understand what factors as in.
Factors which will affect the response with glasses in a patient with accommodative esotropia.
Okay, so now again, if there are no red flag signs, so if there is no oblique overaction, there is no associated DVD, there is no amblyopia, then these are relatively poor factors and can lead to poor prognosis, and maybe my hyperopic correction may not be will give the full complete correction of the deviation. However, moderate plus lenses, onset of age is earlier, that less than 4 years of age. Early onset, no amblyopia, moderate or mild plus lenses, a small angle deviation or small and moderate angle deviation. These are the ones which definitely have, I know that these children will do well with my plus lenses and they will have complete correction of these. These are the good signs, and the other ones which I mentioned are the red flag signs for RA, refractive accommodation.
So I think that covers almost all the aspects of esotropia in great details. Thank you for the wonderful lecture.
Thank you, Gunjan.
I think we have,
Thank you, Janil. And
here.
Gunjan, you are the perfect moderator. Huh? You are keeping a book with yourself and asking questions. Okay, thank you, Janil. And I would like to say one thing about today's class. When I was a faculty at LVP Bhubaneswar, Janil was my student. When I came back to RP Center, Gunjan was my student. And then Pranita was also my student. So all my 3 students are doing this lecture today. So I'm very happy for that. And Janil, you really took a wonderful lecture. Squint is a very difficult topic. Even I fail to understand nowadays after doing cornea for 10 more years. So it's very difficult for students. And Janil, as Pranita might have told you, so what we have decided, we'll share the PDF of PPTs with the students.
Sure.
And if you don't mind, so please share the PDF of your PPT.
Okay.
So that we can share in our DOS-PEP group. And if any questions, any queries are there, then student can put it in the DOS-PEP group, or they can send it to me or Gunjan or Pranita.
Sure. Definitely. I'd be happy to do it.
Thank you again. And I think, Pranita, we
so
can
much,
conclude now.
Yes, sir. Thank you so much, sir, for taking out your valuable time and that exhaustive talk and covering up the entire subject so well. And with that, we'll conclude this class on ESODEVIATIONs today. Thank you. Good night.
We have some appreciation certificate for you, Janil. And I think I'll share it through email to you. And if possible, if you join us at our annual DOS, we'll give you a frame certificate for that.
Sure. Thank you so much for this, Dr. Praful. Very happy to teach residents and learn also at the same time. Thank you for inviting me.
Thank
Good
you,
night,
sir.
all.